بسم الله الرحمن الرحيم. سعادة اللواء طبيب الشيخ سلمان بن عبد الله آل خليفة، قائد مستشفى الملك حمد الجامعي، نائب راعي المؤتمر. الضيوف الكرام، أولياء الأمور الأفاضل، السلام عليكم ورحمة الله وبركاته. منذ تأسيسها في عام 2004 وجمعية البحرين للأطفال ذوي الصعوبات في السلوك والتواصل، وحتى اليوم والذي وصل فيه عدد الأطفال الملتحقين بمركز عالية للتدخل المبكر وصل فيه إلى 160 طفلاً في الفترتين الصباحية والمسائية، والكثير غيرهم ما زالوا على قائمة الانتظار. منذ تأسيسها والجمعية تبذل أقصى جهدها من أجل توفير فرصة تطوير قدرة الأطفال من ذوي الصعوبات في السلوك والتواصل وممن يعانون من التوحد، إضافة إلى مساعدة أسرهم من أجل المشاركة والاندماج بشكل تام مع بقية أفراد المجتمع. وما هذا المؤتمر الدولي للتوحد إلا استمرار لهذه الجهود التي تبذلها الجمعية لأجل تقديم أقصى الاستفادة لهؤلاء الأطفال وأولياء أمورهم. ضيوفنا الكرام، كل عام تنظم الجمعية نشاطاً خاصاً تزامناً واليوم العالمي للتوحد الذي يصادف 2 أبريل. في العام الماضي أقامت عرضاً للأزياء أبطاله أطفال مركز عالية للتوحد، بدءاً من العروض ومروراً بتصميم الأزياء، حيث شارك في تصميم بعض أزيائه الطالب حسين حاجي، والذي يشارك هذا العام ببعض من رسوماته في المعرض الذي يقام خارج هذه القاعة. حول هذا النشاط الذي يعد الأول من نوعه على مستوى الخليج العربي نعرض عليكم هذا الفيلم القصير. حفظ الله أبناءنا وبناتنا وأدامهم ذخرا لأهلهم ولبلدهم. يتفضل الآن الشيخ محمد بن راشد آل خليفة، الأمين المالي لجمعية البحرين للأطفال ذوي الصعوبات في السلوك والتواصل، بتقديم هدية تذكارية لسعادة اللواء طبيب الشيخ سلمان بن عطية الله آل خليفة قائد مستشفى الملك حمد الجامعي نائب راعي المؤتمر. في الختام نتقدم بالشكر الجزيل لنائب راعي المؤتمر على تفضله بالحضور وإعلان بدء فعاليات هذا المؤتمر. شكرا لكم أعزائي الحضور، ونتمنى لكم الجلوس في القاعة حتى إعلان بدء جلسات المؤتمر، متمنية كل التوفيق لكافة جلساته والنجاح للجمعية في تحقيق كافة مشاريعها المستقبلية، والتي تأتي على رأسها مؤسسة دار عالية لبناء وتشغيل مرفق سكني للبالغين المتأخرين في النمو. شكرا لكم والسلام عليكم ورحمة الله وبركاته.
بشكر الشيخ موجودين ان شاء الله.
Dr. J. Douglas Brown, certified neurologist specializing in functional, cognitive, and behavioral neurology. Lecture topic: novel therapeutic approaches to the autism spectrum patient.
We're going to talk about the brain, first of all. We're going to talk about a few basics and some things and principles that are very, very important to understand what we're doing with the brain today and what we're doing with autism. First of all, the brain is made up of 100 billion, that is with a B, 100 billion neurons. Half of those neurons are in the large part of the cortex, the top part. The other half is in the small part under the brain called the cerebellum. Now there's 100 billion of these neurons. Now we know, we may have heard that neurons are made up of axons and dendrites and those structures. That's just neurons. There are an unlimited number of other cells that are next to the neuron, called glial cells. Now these neurons can connect to one another individually by some 10,000 times. And there's other types of cells called astrocytes that can connect to their neighbors some 100,000 times. A mathematician did the math once, and he said, if you consider all the connections that are possible in the human brain, there would be more connections possible than there are particles in the universe. So it's vast and it's limitless what the brain can do. And we've learned that it's also changeable, plastic, if you will. We like to use that term, meaning that the brain can change and improve. Now, for the past many, many years, it's been taught that when neurons die, they're gone forever. Well, I'm going to show you with dementia and Alzheimer's disease that is not true. We've actually seen on MRI, and we see it regularly now, when we start a patient who has Alzheimer's disease, we'll see that the hippocampus part of the brain is smaller. It's abnormally small. But after therapy and proper treatment, we do another MRI, and there it is. It's back, telling us then that this is not true. That when the neurons are dead, we can still make new connections. We know that we can now. So then, there are some 10,000 different types of neurons. They're named basically on the way that they're designed, what they look like, the way they branch out. They may be named on where they're located, perhaps what they do. We have some 200 different neurotransmitters that we are aware of, and we're still discovering them all the time. You've probably heard of the most common: serotonin, dopamine, norepinephrine. We've all heard of those, but that's only 3 out of 200 that we know of and are continuing to grow. Which means we are just beginning to scratch the surface of the brain and what it's doing. So, I said 80 billion here, but we're getting closer to 100 now, we know that. This is a slide of, how clear is it? Of the neurons. These are the long neurons, the axons and the dendrites. But you see all that empty space, all the black space in between them? We never really are told from the textbooks what those are. What's in there? Well, what's in there is glial cells. Billions and billions of glial cells that are active. They're active like neurons. They're doing something. But see, these don't have that long extension of the dendrite or the axon. No, they're real short and they connect right to one another. We don't know what those little things are doing yet. We're just beginning to figure this out too, to see what they're doing. They're transmitting neurotransmitters just directly to one another. They're not using these axon dendrite terminal that we're familiar with. So what does the brain need? Of course the human brain has to have oxygen, that's obvious, right? But it lives on glucose, sugar. That's the fuel that the brain cells use to function, glucose. Which is why doctors, we have such a fit whenever you eat too much sugar. And we want you to not have a high sugar or high carbohydrate diet because it's so lethal to the brain. And we don't like blood sugars to go up and down. We don't like the insulin levels to go up and down because of the damage that it does to the brain. Other doctors in here will tell you it's a bad thing. We need blood sugars to be nice and calm. So, obviously vitamins and minerals are needed. Amino acids are needed. We have to have those to build the cell components because we're bringing cells back when we work with the brain. We're changing it. We're modifying it. We must have all of this in place in order for the brain to be able to function right. So we're setting up an environment when we treat patients with brain disorders of any kind. We're setting up the environment that is most conducive to healing and to health. That's the goal. Now, it also needs stimulation. This isn't talked about very much in neurology, the importance of stimulation. But as an example, you think of a patient with Parkinson's disease. You may have seen someone with Parkinson's disease. They have that tremor, that resting tremor. Now, once upon a time, we thought that that tremor was a symptom of Parkinson's disease. But because we started doing deep brain stimulation, we have discovered that that's not a symptom at all. You see, whenever the hand moves like this, there are stretch receptors, joint mechanoreceptors, tendon receptors that show stretch. There's muscle receptors. All of this information comes from the hand, and it goes up to the brain, to the deeper structures of the brain, thus stimulating it, helping it to stay alive. If neurons are not stimulated, they're dying. It's that simple. So this tremor that we see with Parkinson's disease is the brain trying to stay alive by using what it has, its own body, that movement. So discoveries like that are leading us to understand more about how the brain works and what it needs to survive and what it needs to heal. Now, looking at the various parts of the brain. We'll start down the bottom. That's the cerebellum. A while ago, I said that there's just as many neurons in that small part of the cerebellum as there are in this entire cortex. It's because they're so close together. Please. It's because they're so closely compact together Now we know then that the cerebellum, since it has as many neurons as the cortex has, it must be really important. You may have been told that it's for coordination and balance. Well, that's true, but there's much more to the cerebellum than that. We're discovering now that the cerebellum stores lots of information such as memorized activities. For example, when you're driving your car, do you have to stop and think, okay, where's my foot? Okay, I gotta move my hand this way, I gotta move my hand that way. No, you don't, do you? Because it's in the cerebellum, stored, it's automatic now. And we're discovering that not only is that there, but emotional constructs are there. Other thought processes, mathematics, writing, reading. If it's automatic, it's going to be in the cerebellum. That's what we're realizing. So that cerebellum then is very, very important to the whole brain. Because we've got the exact number of neurons down there in that cerebellum that send information up through this cortex. And what happens when that gets sent? Stimulation. And how important is stimulation? To the brain and to the cells of the brain, it means life and death. It's critical. So looking at the next part. The temporal lobe. You can tell by the way where it's located, it would be associated with hearing. Yes, it is. Now, one important thing to understand is information that comes from the right side of the body comes up and crosses over to stimulate the opposite cortex. Now, that's everything, too. That's not just touch and movement, no. That's light. That's sound. It all crosses over to stimulate the opposite side. Very important concept to understand when it comes to treating the brain. So then, the temporal lobe, associated with hearing, but it's associated with more than that. And the left temporal lobe is associated with the written language, period, the ability to speak it, and the ability to choose which words we want to say. Now, when I compartmentalize the way I'm doing right now, it's not absolute. Obviously, there's other parts of the brain involved, and I'll explain that as we go along. But in general, this is what these parts of the brain do. I wanted to show you this picture to demonstrate another important concept. The brain is divided into hemispheres, a right side and a left side. Now, they're connected by this corpus callosum in the middle. That's how the right and left hemispheres communicate with one another. Now, how important is this, you might wonder? Well, back in the 60s, because of epilepsy, it was decided to try a technique called a colostomy, wherein the neurosurgeon cuts through the corpus callosum to divide the two hemispheres so that they can no longer communicate. Now, why would he do this? Well, it was discovered that a seizure starts at some point of the brain. And when it starts, it has a tendency to spread from that area and cross over to the other hemisphere. Well, it was thought then, if we can keep that from happening, perhaps we can stop these grand mal seizures from happening, the really bad seizures. So they did it. And indeed, it worked. But there's a couple of good, really well-documented cases in the textbooks that are interesting. One, the lady comes back to the doctor and she says, "You've ruined my life." He goes, "What do you mean I ruined your life?" She says, "You've ruined my life because I love to read and I can't read anymore thanks to you." He says, "What? Why?" She says, "Well, when I'm sitting there trying to read the book now, I'm sitting there quietly reading and my left hand keeps closing the book on me by itself." Well, since the right side of the brain controls the left side of the body, we discovered then that the right side of the brain can't read at all. So, here they are, they're both divided. They're sitting there, the right side's getting bored because he just sees a bunch of nonsense and he closes the book. That told us then that the sides of the brain are very different. It is as though we have two different personalities within our own head. All of us do. Another documented case was, a man was complaining about the surgery too. He said, it doesn't happen all the time, but very often, when I want to go out, I'm putting my clothes on with one hand and the other hand's taking them off. Because one side doesn't want to do that, whereas the other side does. So we see there's two different individuals. And that's why that corpus callosum is so critical to the function of the brain. They must communicate continuously. Very important. Now what we're finding is the right side is primarily, speaking of the frontal lobes now, it's often associated with emotion, creativity, love. So obviously the right frontal lobe is important. The left frontal lobe, however, is associated with linear and logical thinking, such as an engineer might have. Very intelligent, very straight, very logical. That's what the left frontal lobe does. The right frontal lobe, total opposite. Look at professional artists. Let's say a musician. They use their right frontal lobe all day long in creating. So what kind of behavior would you expect from them if they use their right frontal lobe all the time? You expect emotion, don't you? A lot of emotion. And isn't that what we get with artists like that? A lot of emotion. Because they're thinking from the right frontal lobe. Therefore, their world is being interpreted by the right frontal lobe. So then, when they think of something or talk to someone, they're looking at the emotional aspects of that conversation or whatever it is that's happening, and they interpret it that way. Whereas, on the opposite, if a person is a left frontal lobe dominant individual, it's all logic. It's all linear thinking. If it's not logical, it won't make any sense. And certainly, emotion is not logical, is it? So then we can see how the right and the left frontal lobes must communicate with one another. They must communicate. Or we get out of balance. We might be overly emotional. Or we might be overly logical. Now, the frontal lobes sit right next to another structure of the brain that's very important. And this is the part of the brain that we use for therapies. It's called the parietal lobe. Now, the parietal lobe is that part of the brain that interprets our world. And each side does a different role. The left parietal lobe interprets the self, us, only us. In other words, it interprets what my limbs are doing on my body, where my head is, and so forth. Whereas the right parietal lobe interprets the room around me, my space around me, and how do I fit in that space? How do I relate to others within this space? That's what the right parietal lobe is doing. So then if you think of autism, and you look at that concept that I just mentioned about the two sides, the two frontal lobes, you can kind of get an idea of where I'm going with this. The left frontal lobe is the most dominant. Now, their left frontal lobe is very associated with self, right? So it would only make sense that that left frontal lobe would not be very concerned about the world on the outside. And that's what we often see. We see the child, a young child, diagnosed with autism. This child may have a take a long time to make eye contact with an individual. Why? Because of that left frontal lobe dominance. If the left frontal lobe is not concerned with you, who you are, what is even happening in the world around you, it's not going to look you in the eye. It's the right frontal lobe that does that. That's its job, is to form an emotional response to what we see. So what we're seeing then with autism is failure of this right frontal lobe. And because it lives next door to the right parietal cortex, we can use the parietal cortex to stimulate the right frontal lobe and thus start waking it up, if you will, bringing it back. Because it's there. It's ready to function. It just can't get activated enough to function. If you talk to someone who has had severe autism and come back, they'll tell you that. They will tell you, I wanted to say these things, but I couldn't. Why? Because it was the right frontal lobe was inhibited. Now that's another concept there, inhibition. When we stimulate one side of our brain, let's say, for example, we need to do some mathematics. We start doing this mathematics. It activates the left frontal, temporal parietal areas of our brain. When we activate one area of the brain, there is an opposite component in the other side, the other hemisphere, that must be equally inhibited. So the more we activate the left side, the more we are inhibiting the right, and vice versa. Which is why if we do, let's say we do art all day, 10 hours a day or so, it becomes more and more hard for us and more difficult for us to be able to access the left frontal lobe and to do things like mathematics. It becomes more frustrating for us, if you will, because we just can't activate that side that we need to. This is what we see with autism. It's difficult to activate the right frontal lobe. So when we look at these characteristics of autism, does not understand people's emotions or feelings. They have difficulty interpreting what other people are feeling or what they're thinking. Now we're talking about sympathy and even empathy. And where would that come from? Well, of course, the right frontal lobe, yes? It would come from there because that's what's interpreting this world and that's what interprets emotion. Without it, we cannot interpret it. We have no knowledge of the emotion. It doesn't exist. I had a patient, this was an adult patient, did not have autism. But he had a wife and 4 daughters. And his wife's like, look, our relationship is in trouble because my husband won't pay attention to me or my 4 daughters. And what does the husband do? Well, he's a computer programmer. So he would sit in front of the computer for 10, 12, 14 hours a day writing code. That takes tremendous focus, doesn't it? Tremendous focus. That's a left frontal lobe activity, focus. So all day long, he's sitting there using his left frontal lobe, which means all day long, he's sitting there inhibiting his right frontal lobe, making him less and less and less sympathetic and unable to read the emotional needs of the family. So they asked me to work with him. I said, well, yeah, I'll do it. There could be a price to pay, though. He's like, what do you mean? I said, well, you know, this job you do takes a lot of focus, and it could be that you lose some of that once we start accessing that right frontal lobe. But he said, no, it's important. I want to understand my daughters and my wife. So we got started. 3 weeks, 4 weeks down the road, he's better. He's doing great. His wife is so happy. 2 weeks after that, I see him back in the office. I quit. Can't do this. I said, what? He says, I am losing my edge. I am losing my edge. I've got to be able to focus precisely all day. And this is getting in the way now. I can't do this anymore. I said, okay, I get it. I understand. I told you it's going to happen. He's like, yep, I'm sure it did. So, he stopped his therapy. He just decided he's going to have to figure this out some other way. But that demonstrates then how each side is so very, very important. The right and the left frontal lobe. How critical that it is. In order to understand the environment around us, our world around us, we need the right frontal lobe and the right parietal lobe to work. Now, the left parietal lobe I mentioned a while ago, remember it's focused on self. Only self. Whereas the right is focused on the whole room, the environment around us. We see a problem with this because of people with ADHD and ADD. Their right frontal lobe is highly active, therefore their right parietal lobe is highly active, and it causes them to be easily distractible. They can't focus. And that's what we see happening with them. We've got too much activity in the right frontal and parietal lobe. Now, many years ago, we discovered there's a system in the brain called mirror neurons. There's a Dr. Ramachandran, who teaches out of UCLA, I believe it is, in California, who has been doing some fantastic research on mirror neurons. Now, what are mirror neurons? Well, they're a system in the brain that mimics what we see. So in order for us to understand our environment around us, when we see someone do something, there are neurons in our brain that mimic that activity so that we can understand what it is. Now, we have inhibiting neurons that keep us from doing what they're doing, but we can understand what they're doing because our neurons are actually duplicating it. That's called mirror neurons. Now, we're seeing this system is failing also in autism. So they don't mirror the activities of others. And we know, of course, this is right frontal lobe and parietal lobe activity that's failing. So if we don't mirror someone else, we're not going to understand them. So these mirror neurons are found in the sensory cortex, which is the parietal lobe, and the inferior parietal lobe. It's important, you notice, in language acquisition and for understanding the actions of people and learning new skills by imitation. It's involved in language with autism. And it is clearly seen to be thinner. When we look at fMRI studies, we can see that it's smaller with patients with autism. So it's very important. Very important. Now, Dr. Ramachandran's work, he did EEGs on children, many children, and adults as well. And he showed that the same brain waves were detected whether they were doing or watching a specific action in normal children. With children with ASD, though, autism spectrum, the brain waves were only detected when they were doing an action, and they were not detected when they were watching someone else do the same action, or even when they were imitating another person's actions. So the mirror neuron system did not and does not activate. This is another approach that we take with patients with autism, is we work to activate that mirror neuron system. A lot of the programs that we see, the methods, the Miller, TEACH, the ABA, they almost always have a motor system approach too, where they're getting the child to get engaged, to do things, to touch things, to move. This is very important. Why? Because of the mirror neuron system and its development. It needs to be stimulated. Oftentimes, I will use gymnastics with patients. And I always use balance and coordination. Now, why do you suppose I'm going to do that? Because I want the child to be able to know the environment that they're in. And when they start understanding their environment, self, balancing, coordination, then I'm activating their right parietal lobe and the mirror neuron system. And when I can do that, the patient starts to understand the world around them. They begin to open up a new world. And they start to see that there's another world out there, that there's other people. And they start to see them, really see them, as we do. Now looking at, again, some of Dr. Ramachandran's work, these are the area of the brain that he has discovered so far where the mirror neuron systems are so very critical. The inferior frontal gyrus, the anterior cingulate gyrus, anterior gyrus in the parietal lobe, and the insula. And the insula, we know, is closely associated with emotion and new memories. This is just a picture of what he was doing with the EEG technology. With the EEGs, we can read the magnetic activity of the brain, the electromagnetic activity. Whenever you stimulate a neuron, you know there's electrical activity. We can see that with EEG. We can see the magnetic side of it. So he's watching. We can watch this brain work. And when we watch the brain work, we see that mirror neuron system is failing in these patients. So when we look at a brain, a functional MRI of the brain of a normal patient and an autistic patient, we can see that the activities are clearly different in each patient. Now I put this here to demonstrate the difference between a brain that is familiar with something versus a brain that is not, and what happens with a normal brain. This is chess. These two people are playing chess. You notice the amateur player, how activated everything is? Because he doesn't know what he's doing. He's looking all over the place trying to figure out how am I supposed to beat this person. And so he's using every part of his brain to figure this out because he's inexperienced. Whereas the professional player, notice this, not nearly as active. Why? Because now the brain knows what it's doing and it has compartmentalized and it has arranged for certain neurons to do it. It's familiar with it now. It's got it now. So I'll show you this to help you understand how the neuron system functions, how the brain is working. It'll start out trying to figure something out by using vast areas of itself, and then once it gets it down, it starts to compartmentalize it. It'll put the information where it needs to go to be the most efficient it can be. And that's what brain's all about, is efficiency. Now looking at this map, on the brain, the parietal, there's a sensory strip and a motor strip. And there's a map of the whole body on this part of the brain. You can imagine that it would be important to have a map of our brain, or our body, on the brain. In order for me to know where my hand is, I need to kind of know that there is a hand. It's really important, right? So we have this map of the whole body on the brain. We can use this map to correct brain disorders. How do we do that? Well, let's say we have a patient with a speech pathology. And I'm having, let's say, the speech pathologist is having a hard time trying to help the child. Well, what can I do? Well, I can not even bother with the speech. I can go over here and let's start doing some hand work. Let's start doing hand therapies. Because I'm stimulating that part of that map And when I stimulate one part of the brain, whatever's next door gets stimulated with it. So I can take that technique and help the patient with speech disorder. By thinking in a different way, we're getting much better results. We can actually directly stimulate it now when we need to, especially with the adults. So with this map, this is the motor strip, which also has a map. The command comes from that motor strip down to the other side of the body to tell it what to do, to tell the muscle to contract. And so we see here an illustration of that, of a child using that map to move his bicep. So there's a motor component, and then there's a sensory component which goes back to another map saying this is what just happened. You just moved your arm. So both of these maps are critical. We see this with dystonia too. It's the breakdown of that map. If that map starts to fail, we get all kinds of problems with walking, for example, with movement, memory, and understanding of our world. So here's a good illustration of these maps. Sensory side and the motor side. Motor side meaning movement. Sensory meaning information coming in after the movement, telling us what's going on. In order for us to walk, that sensory strip has got to be really good. It's got to work really well. We see it when it starts to fail with patients, again, when you think of a patient with Parkinson's. You'll notice the Parkinsonian gait. It's very short steps, and they look at the ground. Why do they walk this way? Because they don't know where their body is in relation to the floor that they're walking on, because the map is failing. In addition to this map, there are deeper structures that we have to be concerned about as well. We have the thalamus part of the brain, and then we have the globus pallidus and pars interna and externa. You may have heard of these called the basal ganglia part of the brain. It is closely associated with Parkinson's disease. You'll notice that whenever information comes from the brain, it goes through these systems down to the body. And when information comes from the body, it also goes through these systems up to the brain. So these are processing units, if you will. They will process this information coming in before it goes to the cortex. So obviously, if there's something wrong with the thalamus part of the brain, that processing is going to be off, meaning that the brain's not getting the right information in the first place. We have to assess that too. And when we do, we can understand better. If there's a basal ganglionic problem in the brain, we know we're going to have a cortex problem. Cortex meaning out here. So we see information coming in, goes to the cortex, information going out, still goes through all these inner structures before it goes to where it needs to go. All these processes must be analyzed to make sure that we're getting proper function of this brain. And that's what we do with details of this kind of work that I do. This is what I spent all of these years working on, is determining how these maps are failing and how we can correct them. Now, I'm not going to go into this. So I think there's someone here that's a naturopath that's going to probably go into the nutrition a lot more than me. But we look at molecular biology. We do look at nutrition. We must. We have to create an environment for the brain that is conducive to health. If a patient has low vitamin D, for example, the brain cannot function like it's supposed to. So I can do all the therapies in the world that I want. If I have that problem and don't correct it, I won't get very far. Because the brain doesn't have the fuel that it needs to work with. Low vitamin B, we've seen that too. And there's an extensive array of tests that we do, looking at everything from thyroid hormone to you name it. All of it. We look at everything. We have to. If we miss anything, that could be the stone that we should have turned over. So looking at the mitochondria. Mitochondria is a small part of the human cell. It's in the neuron too. It is basically the generator of energy for that cell, the mitochondria. And the mitochondria is a generator that has its own DNA as well. So it can change itself and it can respond to needs. If there's a higher need of energy, it can respond to that and change its DNA so that that higher need is met from henceforth. So mitochondria. Now what does it do? We see that the neurosynapses are areas of high energy consumption, and they're therefore especially dependent on the mitochondrial function. The brain weighs on average about 3 pounds. And that's it. So it's a small percentage of the human body. But it consumes 20% of all that we take in. All the nutrients, even the oxygen, 20%. So it is an energy-consuming machine, the brain is. So these mitochondria then are very important. We see them concentrated in the dendritic and the axonal termini, where they have an important role in the production of energy, ATP. Calcium homeostasis and synaptic plasticity. Remember we talked a little bit about synaptic plasticity and that the brain is changeable and it becomes better. Whenever we fire a neuron, that neuron becomes stronger for the next time when we fire it again. Mitochondrial dysfunction can lead to reduced synaptic neurotransmitter release, and the neurons that have high firing rates, such as the GABAergic neurons, may be the most adversely affected. Mitochondria also have an important role in the cellular lipid metabolism, signaling, and repair. So then, neurons have high firing rates. We know that. Therefore, we've got to then consider how the functioning of the mitochondria are. How well are they doing? We have to look at that. So we look at the amino acids in detail. We look at blood work in detail. We can see then how well these are doing. We can see how well they're functioning. Mitochondrial dysfunction in autism. This is a research done and published in Molecular Psychology of 2012. Systematic review and meta-analysis. We examine evidence of overlap between ASD and mitochondrial dysfunction. From our analysis, MD was reported in 5% of children with ASD. We also found that there is a rather high prevalence of abnormal values of direct and indirect biochemical markers of mitochondrial dysfunction in the general population of children with ASD. Now you think, well, 5%, that's a small number. That can't be that important. It is if you're in that 5%. It becomes very important to you and your family. And that's one of the reasons why we look at this too. There again, if we look at everything but this, we've just missed 5% of the patients. We've just missed them, and we could have helped. So then, the variability of the value of these biochemical markers was, for the most part, significantly larger in the ASD group as compared with the control groups, indicating the ASD population manifests a wide variety of values of biochemical markers for mitochondrial dysfunction. So, we don't know for certainty if this contributes to the development of the pathogenesis of the ASD. We don't know if that's the cause of it or not. We just see it, it's there. We see these abnormalities are present, but we don't know if it was there that caused it or if it became an issue after it developed. Now, someone had asked me about immunizations. Now, the research does not prove that the MMR is an issue. It doesn't show it. It just don't. Now, can it happen? It has happened occasionally. It does. I've had two patients that have seen that way. But does that mean it didn't? Does that mean that's the reason? We don't know. We can't dogmatically say that yet. Can't do it. Because if it was true, wouldn't everyone be developing it? Because we all get the MMR, right? So, this is the prevalence of the mitochondrial abnormalities that we're seeing in these cases. Elevated lactate, 31% of the patients were seeing that. Pyruvate, 13%. Lactate-pyruvate ratio is often 27.6%. Total carnitine, 9%. So we're seeing these abnormalities in these patients. Now, if a person has a blatant mitochondrial dysfunction, we will see these types of conditions. So that when we, as doctors, we see a patient come in with one of these conditions, we start thinking this way. We start thinking, okay, this is a metabolic problem. We need to figure out how this happened. So then we see motor delay. Where do we see motor delay? We do see that in autism, don't we? Slow to walk, a little bit of ataxia, balance problems sometimes, don't we? So we have to think about that. Okay, maybe it's mitochondrial too, so we must explore the possibility. MTHFR, methylene tetrahydrofolate reductase. A long word, and what it does is it breaks down B12, to put it simply. Folate is broken down to methylfolate. Methylfolate is what our brain uses. If we can't break down that folate to methylfolate, we can't use it. We can't use the folate. That's simple. Now, we test the DNA now to see if the patient actually codes for the ability to break that down, that folate to methylfolate. If they have that MTHFR, if they're able to utilize it. If they code well, then we can then consider, okay, it's probably not that. But often they don't. And so we must supplement them, methylfolate, rather than give them folate. But if we don't look, we don't know, do we? Again, it has to be considered. So you can see then, the approach we're taking now is a very broad spectrum, comprehensive approach to patients with any brain disorder. And actually, I take this approach with my patients with even depression, because we're seeing a lot of this with depression as well. Another factor is the microbiome. This is the bacteria that live within us, in our digestive tract. We have discovered, fairly recently, that serotonin that your brain uses, about 80% of that serotonin is actually made by the bacteria who live in our gut. Fascinating, isn't it? This symbiotic relationship that we have. Microbiologists are now saying that there are more bacteria that live on us and in us than there are cells that make us. So we are very much a part of the world we live in. Very much a part. So this microbiome starts off at birth. The first introduction is at birth. Some microbiologists are saying that, well, then we need to really think carefully about C-section births because of the importance of this. We have to think really carefully about the way we feed our children. Again, because this microbiome is so important, it must be developed. The baby's not born with it. For the most part, the babies are born clean slate. They need this bacteria to be introduced to them. by the mother. So mother's health is very important to the health of the brain of the child. Interesting information that you may have seen too is the phenomena of fever. We don't know why this happens, but in some cases, a child that develops a fever, a high fever, suddenly the symptoms of autism go away. I don't know if you've heard of this or not. There's well-documented cases of this happening. And that tells us in the research community, well, that means it can be taken care of, then it can be helped. If a simple matter of elevating body temperature changes the brain that much that the patient becomes able to communicate and understand someone else, we really need to be looking at that more carefully, and we are. There are many researchers that are looking at this phenomenon, but as you can imagine, it's not like you can go and induce fevers on everybody. That's, it's not very good medicine. So we have to observe, and we get parents to do that. We get parents to observe and watch the child. If the child develops, if they develop much less symptomatology during a fever, then we're on to something. Here's another factor that we're seeing. Elevated blood serotonin levels. It's one of the first biomarkers identified in autism. Many studies have contrasted blood HT levels in autistic patients and controls. Despite some limitations, mainly due to small study sample sizes, our results significantly reinforce the reliability of elevated 5-HT blood levels as a biomarker for ASD, providing practical indications potentially useful for the inclusion of multi-marker diagnostic panels for clinical use. But see, this is the thing. If we just look at this and say, okay, yep, there we go. We've got elevated serotonin levels. Well, that's great. What are we going to do about it? If we just stop there, we get nowhere, don't we? It's like looking outside and seeing the rainfall and say, oh, yep, there's rain. It's going to rain today. What use was that? None. So we have to apply these discoveries. We have to apply all these things we're learning in research. Like, what is the significance of this? Well, we now know that with elevated serotonin levels, it creates a cascade of events, a domino effect, if you will, of other neurotransmitters, making them lower, like dopamine, norepinephrine, GABAergic, serotonin, or other GABAergic neurotransmitters. It's lowering them because it's elevated. So therefore then, again, we go back and look at the mitochondrial function. We go back and look at amino acids. We look again at MTHFR. We're also discovering that thyroid levels affected. Thyroid levels, if you all can imagine that, affecting brain function. It turns out that thyroxine stimulates the brain, like coffee, keeping it active. Therefore, if it's too low, it's going to be inactive. And what we've seen is, it's the activity of specific areas of the brain that we've got to have normal function of the brain. So, thyroid affects it, and other hormones affect it. We're going to talk about Alzheimer's in a little bit, because I just wanted to explain it so you have a better understanding of where I'm coming from. But I had one patient. She was reversing. The Alzheimer's was reversing as expected. And then she plateaued. She stopped. And so we had to go back and look at everything, and we discovered that her estrogen was a little bit low. This lady was 74 years old. You might think, why would a 74-year-old woman need estrogen like that? Well, it turns out that when we gave her estrogen, supplemented it for her cognitive function started to go up again. But she, at 74, was suffering from estrogen withdrawal. And that is what was causing her cognitive, her brain decline. One little aspect, that's why I call them stones. If we do not turn that stone over, it could be the one. And in her case, it was. That was one single variable that we had to check on and fix, and that helped that woman. So it's very important that we must have a comprehensive approach. Now, as I said, we were talking about Alzheimer's disease. And what we're seeing with Alzheimer's disease clarifies a little more about how the brain works, what we're discovering. When we look at what's happening in the brain of Alzheimer's patients, is that neurons' connections are slowly dying off. It turns out that the brain goes through a process of pruning, if you will. Neurons' connections are broken, and then there are neuron connections that are built up and made new. There's new ones being built all the time, and old ones being broken down all the time. Just like the bones, if you will. Imagine that. In the bones, new bone is being made all the time, whereas old bone is being broken down all the time. In osteoporosis, we see the effect of not enough new bone being built up while the old bone is being broken down, so we get a net loss of bone. We're seeing this in dementia, in Alzheimer's. It is the same process. We are losing connections faster than we are gaining and maintaining. But now we understand how to gain them back and how to maintain them. This is an example of a brain with Alzheimer's disease. So we see it's advanced. You can see the shrinking of the brain. So the connections are slowly dying, and the brain is shrinking as they die. Why do they die? Well, as with all brain disorders, it tends to be the same cause. They're missing something. Like I said, it could be hormone, nutrition, a lack of stimulation, or all the above. But they are missing something, and it's not allowing the brain cells to survive. And so the connections break down, they start coming apart. Now, if we stimulate that brain, if we give it the proper nutrition that it needs, we give it the environment that it needs to thrive in, then we see it return. Now there's a study done by Dr. Dale Bredesen at UCLA, California. He's at what we call the Buck Institute, B-U-C-K, Dale Bredesen. He does research on Alzheimer's disease. And he does mainly his research is on the metabolic enhancement side of what we do. He doesn't do all the other things that I do with the pathways and so forth, but he does the metabolic enhancement. Now, he started off with 10 patients in his research. They all had Alzheimer's disease, all of them, meaning that they'd lost their memory and they were beginning to have problems taking care of themselves. That's when we start saying this is Alzheimer's disease, and when a person can no longer take care of themselves. Up to that time, we're just calling it dementia. But they all had, there's 10 of them, they all had Alzheimer's disease. He started this metabolic process with all 10 of them. Now, one of these patients was what we call late stage or end stage Alzheimer's disease. Very sick individual. Started him on the metabolic treatment. And within 6 months, all 9 of the ones that were not the most diseased reversed. They all reversed. 6 of those 9 actually went back to work. And that's how effective it is. That's what we're learning. But the one, though, that was end stage, nothing helped that person because it was too late. So with Alzheimer's disease, we know now that there's a point of no return. There's a point at which we can't do anything. too late. And that's what the case was with that patient. It was just too late. There wasn't enough to work with anymore. So the story is, the moral of that story is, don't wait to get treated if you know someone with dementia. As I mentioned, the NIN study, the improvements that I mentioned have been sustained, and they are still going on. This is 3 years ago. The improvements stay. They continue to be maintained. However, we put these patients on a diet, a specific diet. We tell them to do certain activities. We change their lifestyle. Now, if they choose to, they can go back to that lifestyle they had before. But guess what's going to happen? They're going to go back to dementia again. Because we are discovering that the environment, what they do, what they eat, their activities, all affect the brain's ability to stay healthy. Now, if it's a bad environment for that brain, it's not going to be able to get better. It's simply not. Now, as a side note, we're starting to understand, or we're starting to describe a phenomenon that we're calling diabetes type 3. You may have heard of it. You know, you have type 1 diabetes with this insulin. The patient can't make their own insulin. You type 2, where they can't use it. And now we're starting to see what we're starting to call type 3. Whereas insulin's okay and the sugar's okay, but the cell can't seem to get it and use it. They can't seem to get the insulin or the sugar then that is there to be utilized by that cell. It's not an insulin issue. It's not a carbohydrate issue. It just can't use the glucose that it gets. And we're talking about the neurons of the brain. So we're starting to call this type 3, particularly in Alzheimer's disease. Now, how are we correcting this? Well, it turns out that the brain can also use ketones for energy. So, if we give the patient a high-fat diet, a low to no carbohydrate diet, and get them to start generating ketones, we can then get energy back into that cell of that dying brain and reverse the dementia. So that we've got that ACE there, the ketones, the brain can use them. Now, do we want to keep them on that diet forever? Not necessarily. We do want to control their carbohydrates, though. This is one of my patients, one of my dementia patients. This is his first examination, and when he tried to draw a clock. This is 5 weeks later. This is 10 weeks later, after he started treatment. So you can see that one side of his brain was much weaker than the other. Because what is he doing here? He's neglecting one entire side of that clock, isn't he? Which means one side of his brain is just basically not functioning. That's the parietal cortex that we talked about earlier. But once we get him back, now he's aware of the world around him. Now he gets it. He knows that there's two sides to the world, and he gets better. And he's much better now. He's able to function again. His life is back. When he was right here, I'll tell you, his family they were terrified. It was coming. I just thought these were kind of humorous and terrifying at the same time of what they used to do for brain disorders. I'm glad we've come a long way. Not doing that anymore. But what are we doing now? Well, we've discovered transcranial magnetic stimulation for depression. And what does this do? Remember, in order for the brain to be alive, it has to be stimulated. And if we stimulate one side of the brain, the equal amount of stimulation we give that side is equal to the amount of inhibition to the other side. Now remember, the right frontal lobe is all about emotion. So then, if a person is depressed, could you imagine which side of their brain that they probably access all the time? Yes, you're right, it's the right frontal lobe. So what we want to do is inhibit that. We want to inhibit that function so that this depression gets better. How do we do it? Well, one technique we're using among the multitude that I've already described is transcranial magnetic stimulation, where we can directly, with a magnet, not electrocution, by the way, with a magnet, we can stimulate the left prefrontal cortex, specifically the dorsolateral prefrontal cortex, on the left, because that's the logical side, isn't it? That's the side where we can reason. And if we can reason, we can then say to ourselves, when we're thinking of these negative thoughts, we can then realize that they're nonsense. And we can get past that depression. And we're getting tremendous results with this. 78% positive results. This alone, when they did the research, they only did that as a variable. And it was 78% cure rate, basically. Now, out of that 78% of that were cured of the depression, 50% did begin to develop symptoms again, but all they needed was a few more treatments and they returned right back to depression again. It's a very powerful tool that we have at our disposal now. Very powerful. Transcranial magnetic stimulation and right frontal lobe enhancement. And notice the article for autism. An international consensus conference held in conjunction with International Meeting Autism Research, 2014. What do we find? Behavioral improvements. The beautiful thing about this treatment is that it works. It absolutely works. It's not a matter of questioning if it's going to do it or not. Because when we directly stimulate the brain, it is working. We don't have to wonder if it's working. It's working. That's the beauty of this new treatment that we're doing now. It's just a fantastic technology. And we're beginning to learn more and more about it, particularly with children. There's a lot of doctors that are doing some beautiful research with children. Adults, we know it works with adults. I use it with patients with depression. I use it with patients with dementia and Alzheimer's disease. And I use it with some children. Not very young children yet, but we're on our way to that. All we're trying to do at the moment is to, by research, determine the right dosage. Once we get it, then we can use it. We want to make sure that it's safe. I don't know if you can see this very well back there, but before the treatment with transcranial magnetic stimulation, we see the cerebral activity is fairly low. But once we treat them, you can notice that it lights up. And it's on the left side is where it lights up. That's exactly where we want it to light up. We want the left side, the left frontal lobe, to be stronger when it comes to depression, because then we can eliminate the depression. Because remember, if I stimulate the left frontal lobe, what am I doing to the right, where the depression comes from? I'm inhibiting it. Therefore, I'm treating that depression and helping that patient. A few examples of some of the tests that we do and what we look at and some of the suggestions that we make. First of all, we talk about optimizing the diet, reducing carbohydrates. Why? Because too much carbohydrate, too much glucose is lethal to neurons and to neuronal connections. So we want to keep the carbohydrates to a minimum. I mean, we could all do that, and it would benefit us all. Not only does that help with insulin and sugar levels, but it also minimizes inflammation. We know that a high carbohydrate diet increases inflammation. We know that. We've seen that with markers such as C-reactive protein and others, where it causes increased C-reactive protein. Diet, the way we eat. Now, I tell all of my patients this, to fast 12 hours each night. So, that means our last meal and breakfast needs to have 12 hours in between. Now, why am I doing this? Well, just last year, a study was published that proved that when we go to sleep, and we go into slow wave sleep, deep sleep, our brain expands just a little. And when it expands, it allows the trash, the stuff we talk about, the tau's, the A-beta peptides that accumulate, things like that, it allows them to literally get washed out because the brain has expanded a little. But if that does not occur, in other words, we don't sleep enough, it doesn't happen. And it accumulates. That's why sleep is so critical. That's why I talk about it. So this also, when we don't have food in our stomach, we don't have blood being diverted to the stomach. That makes it possible then for the pressure to increase to allow our brain to expand like it should when we're asleep. However, if we have a stomach full of food when we go to sleep, well, that blood is being diverted. And that could be a cause of the accumulation of these tau's and A-betas. Stress. Meditation, yoga, music. There's a variety of ways we can manage stress. We know what stress does to us. All of us know that, right? But it's the way we manage it. There's many, many ways to manage stress. But that will reduce the cortisol, and it will help us to be healthier and less inflammatory, if you will. Because inflammation destroys neurons, which destroys connections, which makes it hard for the brain to function like it's supposed to. That affects everything. That affects patients with autism, depression, Alzheimer's disease, and it goes on and on. Sleep. I prefer 8 hours. Some of you are probably thinking, man, you're lazy. All I need is 3. We really need that sleep because we're doing neuronal repair when we sleep. Remember, we talked about the pruning. We're doing some pruning while we're sleeping. We're clearing out the old connections that we don't need. Now you think, why would the brain destroy connections? Well, it's not really important to remember the 5th song that you heard on the radio today, is it? No. That's a non-necessary memory. So it needs to go. The brain gets rid of it. And it does it every night when we're sleeping. Exercise, very important. I tell people 30 to 60 minutes a day, 4 to 6 days a week. Very important. If there's not enough blood flow to the brain, it's not going to be healthy. It can't be healthy. Now, brain stimulation, we talked about that. Now, these chemicals here, these are the things that I test. These are some of the things I test. I look at the homocysteine. That has to do with B12. We look at the B12 levels. I wrote here, over 500 is where I like for them to be, but I actually prefer to optimize the brain. I like it to be around 900. I do. So that the brain has plenty to access when it needs it. C-reactive protein, we test for that because we're looking at inflammation. That's an indicator of inflammation. If it's high, we know there's inflammation, and inflammation is detrimental to brain connections and to the brain itself. So we must test that and deal with it. Insulin levels, hemoglobin A1C. All of you have heard your doctor talk about this over and over again. And they harp on that all the time, don't they? Well, when it comes to the brain, it's very, very important. It's critical to the life of the neurons of the brain. Without that being maintained properly, too much insulin, too little sugar, your brain can't live, neurons start to die. It's just that simple. And there's a very delicate balance there that we must maintain. Hormone balance. Remember we talked a little bit about the estrogen with that one patient earlier. Thyroid is also important. T3. I test for T3, I test for T4, and also test for TSH, the thyroid stimulating hormone, all 3 of those. A lot of doctors wonder why I do that. Well, I want to see that the T4 is being converted to the T3. And I want to know how hard it is for the brain to get that to happen by means of the TSH. I'm looking at all of this at once. The T3, for brain optimization, I like for it to be around 3. Yeah, that's a little high, but that's where I like for it to be for brain, to optimize the brain's function, to get the best out of our brain. GI health. We talked about probiotics, prebiotics. The GI health is very important. Remember, 80%, right, of the serotonin is made by those bacteria that live in the gut. So it's important we take care of them too. So, like with antibiotic therapy, if your doctor says you have a virus, don't demand an antibiotic, please. He may be willing to give it to you anyway, but please don't demand it, because he's not going to want to give you that antibiotic because he knows it's a virus. You're not going to help it, and you're only going to hurt the gut. You're going to hurt the bacteria that live there. And that can lead to a cascade of other problems, of which we won't get into here. So GI health. With my Parkinson's patients, I want to treat for the accumulation of A-beta. We've seen that these two herbs, curcumin, ashwagandha, do that. They actually help that. Cognitive enhancement, Bacopa, Monera helps. Magnesium, it helps. We've seen these in well-documented studies. Vitamin D3. The normal range that you'll see with labs with vitamin D is a 30 to 100. Now we know the brain can't function well if that vitamin D level is less than 70. Your vitamin D level needs to be 70 or above. If it's less than that, you're not optimal with your brain. And you're thinking, well, my doctor said my vitamin D was 31. I'm fine. I'm in normal range. No, you're not optimum. Normal, yes, but not optimum. We want optimum. We want our brain to function at its maximum. We want to increase nerve growth factor. We can do that. And we also look at acetylcholine and DHA. One test that I like to do is called optokinetics. This is one of the tests that I use to determine what aspects of the brain are weaker, or not firing properly in comparison to others. Now, if you can imagine this test this way. Let's say you're sitting at a stoplight. But you don't have a lot of stoplights here, but imagine you're sitting at a stoplight and there's cars passing in front of you. You will now notice that when the car passes in front of you, you automatically follow that car. That's called a pursuit. Now, you follow it for a certain distance and then your eyes come back. We call that a saccade. Now, what makes you pursue is the parietal lobe on the side of the pursuit. And what makes you come back is the frontal lobe on the other side. And what makes you stop in the center is the cerebellum on the other side. So I use that system to analyze the function of the frontal lobes, the parietal lobes, and the cerebellum by watching the movement of the eyes. Now you can, it'll work, let's see. Yeah. So we do that tracking test right there. You might notice your eyes are doing it right now. They'll go bump, 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 while they're following it. That's normal. That's pursuits and saccades. That's what we're looking at. But it gives me another window to look inside the brain to see, okay, now what's functioning at a minimum and what is functioning at a maximum. Sometimes I will see that one part of the brain literally is functioning at such a high level that it's overcoming other parts. So we have to bring it down a little bit to make it to where everything's balanced out in that brain and everything can function properly. We do look at this with autism. We look at all these things I've just mentioned, we look at with autism. So we can get a comprehensive approach to the treatment of these patients, to helping them. Now, I'm not going to talk about ADHD, by the way. I'm not going to bore you any more than that. I already have. Now, when it comes to autism, we look at these patients, and, you know, frankly, I really love the way they think, for the most part, personally. So the only thing I look at when I'm treating them, I'm only trying to help them to be able to understand others. That's really what I want. I I want them to be able to socialize. I want them to be able to see someone's face and know how they feel. I want them to be able to know what love is and to have a good relationship. That's what we're doing. That's our goal. We're not. I don't like to take a patient and say, okay, I want to make them normal. Well, what is normal? You know, me? You know, I think they're fantastic. I think they're wonderful people. I love the way they are. So all I want to do then is just open them up some to get them to where they can see their world. And I think if you know someone with autism, I think you can agree that they're wonderful. And we don't want to take that away. We just want to help them out a little bit. I don't know. Can I take questions? Is that, yes? Okay. Do I have any questions? Do we have time? And let me know when I run out of time, okay? I'm not watching the clock, so let me know when I run out of time. Okay. Yes?
Thank you. Shireen Rafi, Advanced Medical. You noted in your talk the effects of hormones on the brain function. And I'm just wondering, in particular, what have you noticed with regards to autism and hormone levels in your patients?
Well, we've looked at testosterone levels being too low, and that affects it. Estrogen as well. Both of them can affect the function of the brain. Therefore, of course, it can affect autistic patients. Yes, certainly. We've seen both. We've seen low testosterone as well as low estrogen. And yeah, even with children.
I have one more question, if that's okay. What, in your opinion, is the most promising therapeutic approach?
Right now?
Yeah.
Now, I'm only going to be coming from my perspective, because I think the Miller method, ABA method, TEACH method, all those are doing great work, fantastic work actually, especially with the younger children that I don't work with. The children I take are 5 years and older. But the most promising, I would say right now, is the transcranial magnetic stimulation. That is what I am personally most excited about. Because comprehensively, we can look at the metabolic side. All of us doctors are trained to do that. We all understand that. Now, we may not look at the details for the most part, most of us, but we can learn it pretty quick. And that can be incorporated fairly easily. But the TMS is a little more complicated to understand for most doctors. Right now, the only ones that are using it are neurologists and psychiatrists. But it is the most promising therapy right now in my world, in my field.
Thank you.
You're welcome.
بسم الله الرحمن الرحيم. الله يعطيكم الصحة والعافية. طبعا احنا نشكر مركز عودي على دائما المؤتمرات المتميزة. شكرا للدكتور عن الورقة هذه القيمة، وطبعا فوجئت جدا بمعنى ان الخلايا العصبية ممكن علاجها وان هي ممكن تتحسن او الوظيفة يقومون بتحفيزها. المهم في الامر، ويمكن هاي يستحدثني حديث الرسول صلى الله عليه وسلم عليه، اللي هو الحبة السوداء شفاء لكل داء الا السام. والسام احنا طبعا نعرف انه هو الموت يقصد فيه. اذا هاي الحبة السوداء انا اتوقع اكيد ان حديث الرسول صلى الله عليه وسلم عليه انها تؤدي الى علاج حتى هذه الخلايا. فهل هو هناك في عندكم يعني بدأت هاي الابحاث فيها، علما بان انا قريت موضوع مره ان دكتوره اسمها موزة المزروعي قامت بعده ابحاث على هاي الحبه السوداء على الكثير من الامراض، منها حتى نزيف لامراه كبيره في السن، وتعالجت بعض الاطفال اللي يولدون عندهم بعض الخلايا معاق، وممكن انا ارسل حق الشيخه والدكتوره سوسن عن الموضوع. فهل ورد عندكم او هل ممكن الاخذ بهاي البحث؟ شكرا.
Hi, she was just asking about the brain's ability to regenerate, basically. And she was asking specifically about, yeah, it's a black seed, a kind of herb. Do you have any? She was asking if you have any information, if any herbal remedies were used for that.
Why onion? Why onion? Why onion seeds? Why onion seeds?
Okay.
Which we use it in the breads and
Okay.
it's a little bit aromatic.
I haven't read any studies, but I do believe we have someone that will be speaking this weekend that can probably cover that.
The saying from our Prophet Muhammad.
I think some of those act as like an anticoagulant for the most part. But I don't know. I'm not going to say I know. I'm not going to.
Thank you very much for this very interesting presentation. I have a question. What do you think about this relatively new, I would say, thought that autism is not a cognitive disorder, it's not a behavioral disorder, but it is a movement disorder?
A movement disorder?
Yes.
Well,
have you heard about it?
that is, to call it a movement disorder, no. It is a cognitive disorder, but the approach that I take is for movement. That's one of the therapies that I use is movement. So yes, and when we looked at the basal ganglia, you know, and we talked about those deep structures and we talked about the motor strip, the importance of that to parietal function, very important. That's why we use those therapies. So yeah, that's a very good observation. Someone, you just reminded me, someone said also that, and I thought this was quite interesting, we're seeing so much more autism today. It's growing. Has it never been here before? I don't think so. I think it's been here, but we're seeing the prevalence of it just escalate. And someone thought that it's possible that this is an adaptation of the brain because of using so much technology. You know, when we interact with a machine, it doesn't have personality. We don't have to read it. Its facial expressions, you know? And so, for the past 20 years, we've had a very technological world that we live in. And some are starting to believe that maybe the result of that is creating this adaptation that we're calling autism. It's just not, I mean, it's a theory. Disproven, but it's a theory. And I thought that was kind of interesting, actually. You know, because people with autism can interact with technology very well. I had a patient just the other day, actually. The mother told me that her child, this is a new patient, she said her child got obsessed with dental videos. And he was going on YouTube and watching all these dental videos. She could not understand why he was doing that. And then one day he said, I want you to see this, come here, come see this, come see this. So she sits down and he says, that's not me, right, Mommy? That's not me. He kept saying this. And finally it dawned on her. He's using these videos to tell me he has a toothache. So she said, are you hurting? That's not me, Mommy, right? That's not me. That's how he was telling her that he had a dental problem. And she took him to the dentist and sure enough he had a cavity. But that's how he was communicating, was through this YouTube. So it was that technology that he was using as an external way of communicating. And there's no other part of the brain that would do that but the left frontal lobe. Since the right frontal lobe has failed, he couldn't tell her in an understanding way of what was happening.
Well, regarding your comment about increase of autism, I'm sure that everybody knows that autism, well, I think we know that autism was here always.
It was.
But the diagnostic process is better now. We know about autism, while 20, 30 years ago we didn't know much about it. So the awareness is here. But also technology, I don't know, maybe yes, maybe it affects us. And there is a new study now, I think I heard about it last week, that Actually, there is a gene, and a gene of autism is in every one of us, and sometimes in myself I see some autistic symptoms from time to time, so I think we can all relate to that.
Yeah, I think we can.
Yeah, so I just wanted to say that I think autistic people were here always, but the problem is that before they were regarded as mentally retarded and put into the asylums and other mental institutions. So that's why there was no autism. Autism is now, but at that time it was different names for that.
Yeah, I agree with you. I do.
Excuse me?
Yes. Oh, I'm sorry.
Thank you, Doctor, for your PowerPoint. It's really very good. And really, the first time I attend a conference for autism, and appreciate all the information that you give us today. What really, I really thank you very much for your coming to Bahrain, and you give us all this information that autism, it's also medical and also therapy. So what I would like to know, for your transcranial magnetic stimulation for our children to benefit from it. So what you are going to bring for us therapy to do it for your children, which is important for us to improve our children so they will be better and better and improve them and benefit from it, which is important for us. And it's really amazing job, and we are happy to have us between us. And really, I'm really happy to know you, and really I will clap for you.
Hi everybody. My name is Viding. I am coming from Istanbul. I have a special question for you. Do you see any relationship between anxiety and autism? What happens with a person who has anxiety in his brain?
Anxiety.
Yeah. And how does the brain function? And do you see a relationship between these two disorders?
Yes,
Thank you.
Of course, yes. With a child with autism, you stress that child out, they shut down. So there's no doubt anxiety affects, we know it affects the brain, it affects all of us. You can't function cognitively under stress, intense anxiety. You can't do it. Your brain will shut down into what some doctors like to call the more older parts of the brain, the more vegetative, if you will, less thinking. That's why I talk so much about meditation. I talk so much about trying to have an environment that is more easy, more calm. A child with autism is very, very important that they have a calm world, because too much activities around them is very anxiety creating, and that shuts them down. Because it does us, if you think of what it does to us, if we're in a very chaotic environment, how well do we function? I know some people are going to tell me, I function perfect in a chaotic environment. No, it's hard to do. But yes, there is a connection between the two. Absolutely. Further questions?
Hi. Question here?
Oh, there we are.
Thanks so much.
This will be the last question.
Last question?
Yes.
Okay.
I just want to say thank you very much. That was extremely informative and a wonderful reminder of the importance of diet, sleep, using meditation and relaxation. My question is around seizures, and within the ASD population you have children who are seizuring frequently versus those who are not. How does the intervention differ when you do have patients that are seizuring?
We have to treat the seizures.
First.
Period. We have to. Because we know that's an aberrant activity. That's an activity that's going to cause more problems. And seizures are dangerous. They must be treated. If we don't treat the seizure, we get nowhere. So they have to be. Medication is usually the way to go when it comes to seizure activity. Yeah. Unless it's due to some other obvious abnormality, we do an MRI. If we see scar tissue there, perhaps the neurosurgeon can deal with that, and that would take care of the seizure.
Thank you.
You're welcome. All right. Thank you so much, everyone.